Welcome to Health System CIO's interview with Dr. John Halamka, president of the Mayo Clinic Platform. I'm Anthony Guerra, founder and editor-in-chief. Dr. Halamka, thanks for joining me.
Well, always wonderful to talk with you. And now, as we begin 2025, thinking about what's top of mind for CIOs, what to believe and not as the press continues to evolve with AI hype would be a thrilling set of conversations.
Yes, and I'm excited to do that. So you are speaking of AI, you were speaking at the Vive conference. I think they're trying to do some fun titles with this, but basically AI shifts ahead is sort of the theme of your talk. So I'm just going to let you, if you want to just explain what some of the things you're going to address that you want to information you want to get in front of people, and we'll go from there.
Well, sure. So I have just returned from both JP Morgan and from Davos. And when you're in those environments, of course, you hear a lot pitches from small companies, queries from investors, policymakers, and the like. And when you ask, well, where is the US and where is the world going with AI? It's sometimes hard to figure it out. Lots of contradictory information. I mean, we've just seen in the last few days some major losses in the stock market because of advances in the generative AI models from China.
Hmm.
Where's this all going to lead? So, in my comments at Vive, what I'll do is try to dissect, well, what does the market want? What are the technologies of 2025 going to enable? What policy changes, and I'm not referring specifically to Trump administration policy changes, but just sort of in general, as I talk to three branches of government in the US and I talk to international leaders, what are we going to see to encourage and accelerate AI? And then what are the cultural changes we're going to see? So here's an interesting example. Would you allow AI to replace your doctor in a specific circumstance? Well, I think many people have said, that sounds not so wonderful. We really always need a human nearby. We always need a human in the middle. What if the only choice you have is no doctor or AI? Is that worth it? Anyway, these are cultural and ethics questions that we're
Hmm.
all going to wrestle with. And 2025 will be a year where we start to get some answers.
Excellent. All right. So, you mentioned what does the market want? You mentioned pitches from small companies. So, I had a great interview yesterday with Roberta Schwartz from Houston Methodist, who's the chief innovation officer down there. And it made me think of something she said, which is if you are a small niche company, that is a very dangerous place to be. And this is one of the classic things that's going on in health systems right now. There are some massive enterprise EHR players. We know who they are: Epic, Oracle slash Cerner, Meditech. I hate to say it, but maybe to a little bit of a lesser degree. I don't know if they're quite playing in the large health system space as much as the other two. So her point was that, and because I asked her specifically about being a niche vendor and the inclination of CIOs and those types to stay in suite, both for integration issues, interoperability issues, cost issues, to stay in suite versus what users request sometimes, which is the one off niche product that they like. It's a little better, perhaps. There is this tug of war between enterprise, and we've been dealing with this for 30 years, right? It used to be called best of breed versus whatever, suite. You mentioned small companies. What are your thoughts on this dynamic, this push and pull between efficiency, if you want to call it, whatever you want to call the benefits of staying in suite versus what you might call innovation mindset, which is going out of suite, and then dealing with the cost of doing that, which is not insignificant?
Well, sure. What a really great question. I talk to CIOs around the world. The CIOs around the world want to buy 1,000 niche products. I've got an AI for ingrown toenail treatment. Oh, I've got an AI for those that have palpitations after coffee, right? I'm, of course, making these things up. But the point being is it is utterly unscalable to have 1,000 niche products. So people say instead, wow, wouldn't it be great if I was best in suite? I'll pick a radiology AI vendor that has 25 algorithms, a cardiology AI vendor that has 25 algorithms. So you're starting to see that trend. But here's a problem, and I'll give you a vision. To your point, we want all these algorithms to be compliant with a digital Hippocratic oath. That is, they'll do no harm, they'll be fair, appropriate, valid, effective, and safe. Now, suppose, and I am going to make this up, Anthony, completely make this up, but I have an algorithm that was developed entirely on residents of Minnesota. It's really great if you're a Scandinavian Lutheran living in a northern climate. And then I want to deploy that algorithm to New Jersey.
Mhm.
Well, fewer Scandinavian Lutherans. Maybe it's not going to work so well. But you know what? There is a health system in New Jersey that has collaborated with a vendor to create a finely tuned algorithm for New Jersey. Wouldn't you want that? Here would be the vision. As you know, the Coalition for Health AI has been working for the last 2 years on guidelines and guardrails for AI, model cards and data cards. Imagine there is a registry that every little vendor could use to say, actually, I have the world's best algorithm for X niche issue, and it works really well in this population. Shouldn't we instrument our EHRs to be a little bit like the Apple App Store? And that is, instead of having to do a procurement for 1,000 niche vendors, which you would never ever do, instead it just says, oh, you need an algorithm for heart disease in New Jersey? The EHR literally goes out to the registry, sees that there's one available, and then there's maybe some sort of value capture, a transaction fee or something. Point being is that you get the benefit of the best algorithm for the patient in front of you right now running, and it's been qualified to be high quality and all the rest to give the answer to the clinician right there at the point of care. So, sure, in the short term, best of suite is all you got. But you hope in the long term, this becomes an auto magical feature of EHRs to ensure the patients get the best treatment consistent with a digital Hippocratic oath.
Very good. You know what's interesting, and you can help me understand this here. You're using the term of buying an algorithm, which is kind of interesting. It's like, how does the term algorithm compare to what we used to call software or what we used to call an app or a vendor? Because now you're talking about buying an algorithm. Isn't it's interesting to me, like what does that mean?
Well, sure. So let me give you a personal example. So, and as you know, I have no privacy of any kind, and it's all good. So I have glaucoma. I have glaucoma because my father had glaucoma. The family history of glaucoma is severe visual loss. I have been on maximal medical therapy for glaucoma for a couple of years, and I'm losing sight in my left eye. So the ophthalmologist says, well, John, there are three operations we could do. One is we could use a laser to ablate the ciliary bodies that produce fluid. Option two is we can cut a little hole in your eyeball so it has kind of a leak, right? That is, it's reducing the pressure, little trap door. Or the third is we could install a valve in your eye so that it's a one-way valve and it keeps the pressure at a low constant. And so that's great. You know, I happen to be from Eastern Europe. I happen to have myopia. That is, my glasses are really thick. What's the best of those three procedures for me? And the answer is, well, I don't know. Well, what if there was an algorithm that was just designed for glaucoma patients that you would run once and you would feed it your lifetime medical record and it would say, oh, what you need is that valve. That's really going to give you the best outcome. So, in effect, what you're buying is not software, but you're buying knowledge because the algorithm is running against a million patients like you and is giving a recommendation. And there's, say, a fee for that. And by the way, I had the shunt installed in my left eye. It's all good.
Excellent, excellent. Oh, let me. So you didn't mention genomics, specifically like your genome, right? Isn't that the end all be all for our genome to be fed into, our genome mixed with our symptoms, mixed with a billion data sets on other patients like us, get that all mixed into an algorithm, and now you really got some personalized, customized medicine.
Oh, the answer is absolutely. It's just early. Remember, I was the second human sequenced in the Personal Genome Project. And so if any one of your listeners wants to go look at my full genome and medical record, personalgenomes.org, patient two. So fine, I have had my genome fully public for more than 15 years. It's my exome, that 3 billion base pairs. Mayo has in fact developed models. We have two studies. We have the Tapestry study with about 100,000 exomes, but in our total data set, about a million exomes. And so we are doing both predictive and generative models based on these exomes. It's truly state of the art. 2025 is really one of the very first times in history where we've had the kind of multimodal data plus exome that we need to create a model as you've described.
All right, let me data sets versus algorithm versus a prompt. How are all these things interacting?
Oh, well, absolutely. So imagine that I want to train an algorithm. Remember, it's only going to be as good as the underlying data that I use to train it, right? If it is on urban males, it's going to be a great algorithm for urban males. But what about rural females, right? And so you want a data set that has three characteristics: depth, as you pointed out, phenotype, genotype, where you live, what you eat, how much activity you have. That's depth. Breadth, number of patients, but heterogeneity, rural, urban, low income, high income, all the rest of that stuff. So data really important. So once the algorithm is developed on that data, then it can be tested against other data sets, and we can understand a little bit about its performance against ground truth. And that is it likely to work for you? How repeatable, how accurate, how trustable is this algorithm going to be? And so I think when you look at the life cycle, it has to be really great data, creating an algorithm that is validated and qualified and tested, and then ultimately deployed in the workflow with an understanding of the risk. So if I said, my algorithm is going to tell you whether you should eat more broccoli or not, that's not a very high risk question, is it?
No.
If it says you should probably have a heart transplant, that's a very high risk question. So, as we say, we go from data to algorithms to qualification, validation to deployment and continuous measurement and feedback, all the while understanding risk.
So, our target audience is the CIOs, but we can think beyond that. Let's say, because there's a lot of titles that do IT, that are IT related in the C suite of a health system now, five or six there could be. So there's lots of folks that are dealing with this stuff. Everything we just discussed, they don't have to be doing this, right? I mean, they're not. I mean, maybe, and again, I mentioned we were going to talk about this, but maybe the biggest of the big should be doing this, playing around, making algorithms and developing data sets, because the small folks are not doing this, right? They're going to, as you said, get an algorithm or buy this kind of stuff. They're not going to be developing. You're developing it, right? At Mayo. I mean, you guys are. So tell me about, let's break it down if you want into three segments: the big, the middle, and the small in terms of health systems. Always, let's say there's a hospital included. So even in the small, they have, if don't have a hospital, we're not talking about them here. So even for the small, they have like one little hospital. Medium, maybe three, four hospitals, and big would be over 10 hospitals. I'm just trying to come up with three buckets. You can define it however you want. I want you to
Right.
talk to the CIOs and maybe any other C suite IT titles in those organizations. Take it one at a time, one, two, and three, and tell me, what the hell am I supposed to be doing around AI? And what do I not need to worry about? Maybe I don't need to worry about it because I'm small. So you don't need to be doing XYZ, but you should be doing ABC. So if you want to run with that, that'd be great.
Absolutely. And so let me stratify it into, as you say, sort of three buckets. So imagine you're a large academic medical center with large amounts of curated data, a fair amount of cloud compute. Maybe you have a good number of data scientists or AI experts. Chances are you're going to be developing predictive and generative AI on your own. And in the case of Mayo, for example, we have a couple of hundred NVIDIA H100s running inside our Rochester location. That is, we can produce an 8 billion parameter foundation model every week. And that's a pretty unusual thing for a hospital to do, but we have the infrastructure, the data, and the people to do it. And that's great because then you can create innovations. We've got 250 predictive algorithms, eight foundation models. If you're a medium sized hospital, probably you're not going to have that infrastructure, but you probably have a reasonable amount of data. And wouldn't you want to take a commercial product and fine tune it to work on your patient population? And there are mechanisms of doing fine tuning. So that is, you buy a product, but then you enhance it with your local data. And that takes some IT and data science time, but it works then for your local population pretty well. If you're a smaller organization, probably you're going to want to partner, and you could partner with maybe a vendor that's going to help you out to make sure it works really well in your environment. Or maybe you're going to partner with an academic affiliate in your region. And that academic affiliate is going to take their innovations and bring them to you first. You may remember that in my role at Mayo, all of Mayo's 73 hospitals that are affiliated, not owned, across the United States are actually in reporting into my group, with the idea that these community hospitals in more rural areas will get the first chance to use any of these innovations and algorithms developed at Mayo for their local populations. And we instrument their EHR and help them.
Mhm.
So please, don't believe that in order to play in the AI game, you need to go talk to NVIDIA and get your own chips or curate millions of patient records. Depending on your size and your resources, there's no question collaboration and partnership can get you started in AI early.
Very good. How would you describe what the CIO is supposed to be doing around AI? And my thought on this, and to help you understand where I'm coming from, is if I want to empower my really, really smart physicians to be able to investigate things, run queries, whatever's on their mind. These are really, really smart people. So my job, I'm thinking, is to create an environment where they almost have a playground and they can go have fun, have at it. I've set it up in a safe way. I know you want to do all this cool stuff. I've created an environment where you can have at it. Does that make sense? Is that the job of the IT executive when it comes to AI?
Can I say it depends?
Okay.
Back on your three levels of stratification. So, what did Mayo do? Mayo created internally an AI factory and gave 86,000 employees access to the AI factory
Yeah.
and said, we've curated the data, we've put in a series of tools, we've put in every open source LLM, low code and no code tools, go for it.
Mm-hmm.
And that we could do. But it may very well be if you're more of a medium or a smaller size. The reality is you have to build governance, good AI governance, and ask the question, what is it that your users, your stakeholders want?
Mm-hmm.
No chief medical officer that I have ever met says, I just need more AI. No, what they say is, oh my God, ambient listening for documentation would be a win because our clinicians are burned out.
Mm-hmm.
Or it's really hard for our primary care doctors to figure out who needs a referral to a cardiologist. If AI could review their data, their EKG, and then figure that out, that would really help me. Whatever the business or clinical problem is, then you can go out as a CIO and help with procurement. And what you also do, we hope, is as you see 2025 bring us data cards and model cards, the idea that we understand how every algorithm was trained and where it works and it doesn't, that the CIO, potentially with the CMIO, is saying, oh, I see, here's a great algorithm. and I look at its mathematical characteristics.
Mhm.
That is, its positive predictive value, what data was used to train it. I think this one's okay for us to buy.
Mhm.
So you become kind of with governance. You understand what they need and then what to buy. It doesn't require that you build an AI factory de novo.
Very good. We understand that it's very important to be responsive to the business needs. Um, about a concern is always if we focus too much on just being responsive, the CIO becomes too passive and becomes just an order taker. You don't want to get ahead of the business, but I'm thinking you do want to, you're supposed to be the IT expert. You do want to inform the business about IT solutions to the problems that they're having that they may not know about. So you don't want to become too passive. Does that make sense?
What a brilliant comment. I've
Oh,
actually
thank you.
had a discussion over the last couple of weeks on the difference between IT as order taker
Yeah,
and IT as leader and innovator.
right.
And so here's a challenge. Back when I was a CIO at Harvard and its hospitals, was there anyone to speak up for the wiring in the walls?
Mm,
No one,
yeah,
right? No one cared about the network. No one cared about cybersecurity. I mean, they care, but they didn't really say, oh, what we really need is two-factor authentication, right? So there are going to be times when the CIO has to take the first step to catalyze change because it's as Henry Ford said. If I would have asked my users what they wanted, they would have said faster horses. Right? So that is, go bring the internal combustion engine to your organization. It's up to you to take that leadership role.
right.
But on the other hand, there will be times when you're going to depend upon bottom up definition of what the, say, business problem and solution might be. And so I was, been on, as you can guess, calls all day with people around the world. And they say, well, what's the best first way to get into AI? I
Mhm,
said, well, don't just ask yourself as the CIO, how do I put AI in my strategic plan? Ask, what are the KPIs the organization wants to achieve, and how do I help them achieve them better and faster with AI? And
right,
then you're not an order taker, but you're a facilitator. So some of your role will be leading by bringing the solution in that they hadn't even thought about.
right, right.
Sometimes will be not order taking, but acceleration of the
Mhm.
existing strategic plan of the organization with AI.
Very interesting stuff. Let's talk a little bit about ROI. I've heard the statements from CIOs and the like that this stuff is quite expensive, especially the ambient listening, the licenses. It can be very expensive, and there's sort of more of a soft ROI here with the whole pajama time, reducing pajama time, and all that, which sounds to me super important. Clinician burnout is probably one of the biggest issues that CIOs are supposed to be helping with. Ambient listening seems to be one of the best, most well or best established tools at being able to help with burnout. But there is this, there is an issue of ROI and cost, and that there's only so much money to go around here. What are your thoughts around that?
So, to your point, ROI can be squishy. I don't know. Is that a fair term?
I love it. Perfect.
Right. So there's certain kinds of ROI that are directly measurable, right? That is, did I order fewer band-aids because I predicted my need? Did I get better reimbursement because I used clinical documentation improvement to submit bills in a better way? I mean, those are measurable and clear. But there are other more soft measures of ROI. What does it cost on average when a healthcare system loses a primary care doctor to burnout?
Mhm.
Well, numbers I've heard are somewhere between half a million and $1 million because you've lost that resource, and the time it takes to replace the resource is long and training is long. And in the meantime, you've lost clinical revenue plus referral revenue and all the rest. So if you say, wow, I put in this ambient listening and I cut my turnover substantially. I mean it's harder to measure, but it's real. But maybe another question is the following, and this is going to sound a little esoteric. When I was in Davos, there was a lot of discussion about the lower birth rates we're seeing in industrialized
Hmm.
countries and the fact that we're having aging societies and super aging societies. And you look at places like, Monaco, Japan, South Korea, where greater than 25% of the population is over 65.
Hmm.
What if there are no doctors and there are no nurses to care for the patients that you have, but AI can help us empower those mid levels, nurse practitioners, EMTs, et cetera, to do more? Or we can better triage our patients so the neurologist sees the patients that only the neurologist can help.
Right.
And suddenly you're using your resources internal to the organization much more efficiently, seeing more patients in more geographies
Right.
at potentially higher acuity. And that
Hmm.
has an ROI. So I think you have to be careful. ROI isn't going to be as simple as cost avoidance.
I want to. Do you recommend using the word squishy with CFOs?
No, no, no. What I would just say is that I have served on budget committees for almost 50 years. And here's the very funny thing you see. When projects are presented, inevitably they have an enormous measurable ROI.
Uh-huh.
And then the budget is granted to them. And
Uh-huh.
almost no one ever follows up five
Right.
years later to see
Right.
if it's true or false.
Right. Right.
So, in your own organization, you're going to have your own accountability. So, be truthful,
Yeah.
right? Help your organization solve its business problems. And hopefully, the ROI, even if it's not directly measurable, will be reasonable,
Right.
rational,
Right.
justified.
Very good. I want to switch gears here a little bit and give you a fun question. I think it's fun. It's really interesting. You guys are an Epic shop?
We are.
Okay. So we got Epic, been dominating for 10 years, completely dominating the space. And then we have Cerner, which gets acquired by Oracle a couple years ago now.
Correct.
Um, so the word that I've been hearing was pretty negative after the acquisition, just nothing positive until about 6 months ago. And I've had a couple interviews with CIOs that have been on Cerner pre-acquisition and are still on Cerner. And I'm hearing a lot of positivity coming, and it's being attributed to the influence of Oracle on Cerner. Finally, they're saying things are being made better, um, sort of more reliable, rollouts more reliable, upgrades better, things just working better. And then there's this built-in AI that they've got, which is sort of really built in, which people like. So there's a little more positivity coming there. I've said in my mind, this is all good and great, but you know, when we and if we ever see an organization that is on Epic announce they are moving to Oracle, that's when you've really got to change. We haven't seen that. All we see is the other way around. We never, ever, ever see coming off of Epic, and going on to Cerner or Oracle. Even when we see that, that'll be big. So it's good to have competition, right? We want competition. We don't want one monolithic, as good as they may be, one monolithic vendor, because it's really hard to stay good if you don't have competition. That's why capitalism kind of works and all that kind of stuff. Anyway, I'm going to throw it to you there and just get your big picture view on the EHR space.
Well, sure. So, why do we have the EHRs that exist in the market today? Well, the answer was think back to high tech, think back to meaningful use.
Hmm.
What did we do? We outlined all of the functions of an EHR that would be necessary to meet certain societal goals to support things like medication safety, device integrity for the FDA, syndromic surveillance for the CDC, quality measures for CMS. When we established all those regulations, the Did we say what's best for the doctor and the nurse? Or did we say what is going to yield the best patient outcome? No, it was a set of process improvements that was geared to dealing with compliance and billing and surveillance and things. So, what am I hearing around the world now? Interesting. As I said, I was just in Switzerland, and the Minister of Health, Education, and Innovation interviewed me for an hour and said, Switzerland doesn't really have an EHR. What would you recommend? I said, well, ask in 2025, given the tools that are available for generative AI, ambient listening devices and wearables, patient reported outcomes, what would you create from a blank sheet of paper
Mm,
that would give patients access to care, faster cures, reduce burden on doctors and nurses? It's a totally different set of questions. So I start to hear from even the incumbent EHR vendors that created the meaningful use compliance systems that they are starting to look at what the EHR of the future should be
mm.
if regulatory constraints changed. And I think what you're hearing from Seema Verma and our colleagues at Oracle, they are starting to take that, AI first vision for the EHR, very different from the can you enter an order or document a problem list of the 2009 EHRs.
So that's fascinating, right? It makes me think of the Steve Jobs Apple decision to essentially they had a good business with the iPod, and they blew it up with the iPhone. And they said to Steve Jobs, and this is my recall from his biography, they said to him, "If we do this, you're going to ruin this product." And he said, "I'd rather destroy my own product with a new product than have someone else do it." So are the do you think the large EHR vendors would need to completely rewrite and create a new EHR, in tandem with the existing one, keep it running, and then that's the go forward? Um, do they need to blow it up, or can you incrementally fix what you have?
Yeah, what a really fascinating question. Because I'm going to have to answer it is it depends on the policy framework.
Uh-huh.
Right. So at the moment, the policy framework of the United States requires compliance with 10,000 pages of Medicare regulations for which blowing up the EHR and starting again isn't rational. So what you start to see is people layering front ends on top of the existing EHR to reduce burden because ambient listening does the entry into the traditional EHR for you. But if you had, say, Switzerland or a country that hadn't yet formulated the regulations, it has the opportunity of rethinking the whole business process.
Yeah.
So for now, I think we're going to see layering on top of, but if there's massive regulatory change, we might say see a wholesale revision.
Fascinating, fascinating. Dr. Halamka, let me just get a final comment from you and then I'll let you go. This has been wonderful. Your best piece of advice, I mean, what you said about listening to your chief medical officer, with that leading and following with that mix, but keeping your ear on the customer, which is your internal customer, sounds so important to keep people grounded with some good governance around it. But I'll leave it to you for your best piece of advice, to the IT executives.
Okay, so this is going to be slightly peculiar advice, but trust me, I've been doing this for decades. When I was a graduate student at MIT, I took a course in electrical engineering and computer science from a guy named Hal Abelson.
Uh-huh.
And here's what he taught me in the early 90s: technology will continuously change, but engineering principles will stay the same. And so he told me always acquire using what he called abstraction layers. So today you may say the best EHR is this one or the best ambient listening is that one. Well, 5 years from now, that's probably not going to be true.
Right.
So always build whatever it is you create without dependency on a
Hmm.
single vendor or a single technology, if you can, with the understanding that, oh, you don't like that product? Take it out and insert a new one. And the idea of an abstraction layer is that you have APIs, you have a platform, you have an architecture that enables you to take sort of these Lego blocks in
Mhm.
and out, and
Mhm.
it gives you incredible agility. So
What it
try
is.
to avoid vendor lock in
Yeah.
and try to recognize change is the one constant we have. And if you have the agility to
Yeah.
change things in and out, you will succeed in the long term.
That's brilliant. I think I think that's one of the hardest things in the industry right now, because what we talked about, this vendor lock-in, this idea of staying in suite, um, it's real. So this is a real tension to from where I think a lot of the CIOs are to where you want them to be. I think that's a big change that they're gonna have to go through. And I'll give you one final comment and let you go.
Yeah. And so my dream is that the EHR becomes the utility you don't pay attention to so much because there are layers of
Mm,
human interaction and AI on top of it that are doing the work and abstracting the administrative burden away. And
mm,
I think we're headed in that general direction.
absolutely. Amazing conversation, Dr. Halamka. Uh, I've known you for 20 years and I've enjoyed every interaction and I hope they continue. I knew you when I had hair and there we go. So God bless you. I hope you're doing okay with your eye and everything. Maybe I'll take a look at your genome later if I have time.
Excellent. Well, have a lovely day. I'll see you at Vive.
Thanks so much. Take care.
See you.